Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I'm Dr. Jennifer Miles Thomas, and in today's episode, we will discuss the political context, both federal and state, through which we advocate for laws that promote AUA's federal and state legislative priorities. Joining me today for this discussion is Dr. Mark Edney. Dr. Edney has been in private practice in Salisbury, Maryland since 2004. He has a long history of state and federal advocacy that spans his entire career. At the national level, he is a former Gallagher Scholar from 2012 to 2013, prior member of the Legislative Affairs Committee, recent past chair of the State Advocacy Committee, and is the current chair-elect of the AUA's Public Policy Council. Welcome, Dr. Edney.
Thank you very much, Jennifer, for having me.
Thank you for coming. We recently just completed the AUA Summit, which was exceptional. What were your thoughts?
I think, in my opinion, one of the best summits ever. I believe this is our fifth. I'll get slapped on the wrist if I got the number wrong, but it's about our fifth summit. Best ever in terms of attendance, in terms of energy, and what we were able to achieve on Capitol Hill with all of our visits. The talks were fantastic. The speakers were excellent, engaging. And I was most impressed that of the more than 300 attendees, 100 of them were residents. We had a tremendous resident showing. And that is so important for the future of the advocacy of our specialty, is to get folks involved early, get them involved, energized. And we definitely saw that. And I, even in between sessions, I had residents coming up to me saying, "Hey, this is super exciting stuff. I wasn't aware of any of this stuff. How can I get involved?" And so we've got a residents committee designed to engage residents. And so the work of that will continue. But it was one of the best summits so far.
I would agree. And definitely the next generation, the sooner they're involved and understand the issues, the better they'll be able to advocate for us.
Absolutely right.
Well, can you just give us a high level? So what are we advocating for? How do you figure out which bills, like what are the issues, and do you divide them in any way?
Sure. Yeah. So there's a process of figuring out what our priorities are. And those are based on semi-annual or biannual surveys that get sent out. We send out a federal level legislative survey every couple of years. And we also, every other year in the off year, send out a state level legislative agenda survey. So we survey the membership and say, hey, what are your pain points? What are you concerned about, in terms of both federal issues and state issues? We collate all of that data, and that strongly informs ultimately what our legislative priorities are. But it's for the committees. And so within the Public Policy Council, we've got Legislative Affairs Committee, which deals with federal issues. And it's for them to pour through their federal level survey data and prioritize what are going to be our objectives as an organization, or at least suggest to the board. And again, all of this comes from the AUA board. It's for the committees to suggest to the board what the priorities ought to be. And most of the time, the board goes along with the committee suggestions. So our federal priorities come out of our Legislative Affairs Committee, and our state priorities come out of our State Affairs Committee, the SAC, which looks at the state level data and prioritizes what are the hot topics going on in the states, and then comes up with a prioritization list. And that goes up to the board ultimately for their approval. And it's really interesting you ask the question. 5 years ago, administrative burden floated to the top of every survey. I mean, it was the stone in the shoe of almost every urologist, whether you were in academic practice or independent practice. The administrative burdens, the prior authorizations, just the bureaucracy getting in the way of us taking good care of our patients. But what's interesting is what's floated up alongside that and almost surpassed it. It's not that prior auth and administrative burden isn't still a significant pain, because it is. What's floated above that this year, and one of our main focuses, was the workforce and workforce shortages. Everybody's short everywhere, and particularly rural areas, but even in urban areas, we're seeing centers where patients have lack of access because of lack of the availability of providers. I practice in rural Eastern Maryland, and there are four of us who cover, really a larger catchment area of 250 to 300,000 people. And we have gaps in our call schedule because based on the volume and what needs to sort of be covered at our hospital, we can't do it all ourselves. And so we're seeing on the Eastern Shore, and they're filling in that call schedule. The hospital is with locum tenens doctors that come in from out of town and spend a week at our hospital to provide coverage. But what we're seeing across specialties is people having to be transferred, for things that really could be taken care of locally. There's just nobody to do it. And we're starting to see excess morbidity and indeed, in some cases, mortality because of lack of availability of coverage. And this is a tremendous stress for us as providers. We spent all those years in training, and we do what we do because we want to provide those services to people when they need them. We want to save lives and we want to make people's lives better. And when we're unable to do that, it creates an incredible moral tension within us. It's called moral injury, the psychologists call it. And it's incredibly uncomfortable to see people suffer from things that are easily treatable because there was nobody around to treat them. There are cases from Washington State where I've talked to colleagues in Oregon where you have the metropolitan areas and then you have the outlying rural areas. And, we all deal with infected stones now, which seem to just be so much more common than they ever used to be. But if you're in rural Western Washington and you have an infected stone and you present to a hospital that doesn't have a urologist available or no interventional radiologists, you may be a couple hours from the next hospital. And that delay in time and transfer, particularly with sepsis, as hours make all of the difference between getting very sick or potentially dying or getting your situation taken care of squarely. So workforce really came to the top, and the AUA has a urology workforce task force led by Dr. Andy Harris from Kentucky, and he has done a phenomenal job in his group of really laying out the scope of the problem. And the way that committee has sort of laid it out conceptually is that there's a supply and demand mismatch with respect to urologic care in the United States. And so on the supply side, we're not making enough urologists. So what are some of the solutions to that? So we have bills in Congress that talk about increasing GME slots, repaying loans if for urologists who agree to go and practice in rural areas. So there's some, nibbling around the edges of the GME issue is one thing. Enhancing the role of APPs in our practices. And again, lots of different urologists have lots of different opinions about what the role of APP should be. And we understand that that's a vibrant conversation that needs to happen practice by practice. But the bottom line is they are a critical part of the solution of the lack of number of docs that we have nationwide. And AUA's policy has always been, from the board level, fully support the integration of APPs into your practice under the leadership of a physician-led team. And that's been longstanding policy and has been very consistent. But within that, there's lots of room to move and grow to be able to provide the services that we need to provide to our patients as we suffer through these workforce shortages. But there's also, that's the supply side of urologic care. On the demand side, what can we start to do to kind of support our primary care colleagues, our urgent care colleagues, to manage conditions that they really ought to be able to manage? The UTI, first or second UTI consults that come into the office. It's like you don't need a urologist to manage a first or second time UTI. Like there's some things you can do here. Initial management of BPH, initial management of ED. We're not offloading these disease processes to these folks, but there's some things that they can do to kind of sort of tee it up, try something first before you refer them in, to try to create that space in our schedule so we can be dealing with the sickest urology patients who are complicated. That's what we were trained to do, and that's what we really ought to be spending our time doing. So what are some of the educational opportunities to sort of help our colleagues in medicine pick up more of the basic load of stuff that they really can be doing under their license before they refer folks? So lots of different things with that workforce issue. But yeah, so it was workforce, absolutely. Administrative burden. And the other thing we advocated for on Capitol Hill was payment adequacy. Everyone knows that the payments from Medicare CMS to physicians, the Medicare physician fee schedule, is the only fee schedule in Washington that's not adjusted annually for inflation. And what that means is over the past 15 years, we effectively, when you consider inflation, have taken a 26% pay cut from our federal payers, from Medicare. And most general adult urology practices are somewhere around 40 to 60% Medicare. So it's a huge part of our practices. So there is work going on in both the House and the Senate. There's a new Senate work group that came together. There are several senators that have come together to start to brainstorm ideas about how to wholesale reform Medicare payments to doctors going forward. And there's a bill in the House that's actually being formulated. And incidentally, one of the huge champions of that House bill is one of our own. There are two urologists in Congress right now, Dr. Greg Murphy and Dr. Neil Dunn from Florida. Dr. Greg Murphy's from North Carolina, and Dr. Murphy's been in a huge, and Dr. Dunn as well, but Dr. Murphy's done a tremendous amount of work to move forward payment reform for doctors. And so, bit of a long-winded answer, but those are the things federally we think about, and that's how we get our priorities. And those are the things this year that were top of mind.
Well, that makes complete sense. How is that different than the state focus?
So it's interesting on the state level, there are a lot of things that are just much more active on the state level because they're quintessential state issues. States, when we talk about medical malpractice reform, yes, there have been federal bills sort of looking at that, but med mal reform tends to be really a state level issue. It's state lawmaking and rulemaking that really affects your environment in terms of medical malpractice in the states. And so we're seeing a lot of that in the states, and a primary way that the plaintiffs bar goes after med mal issues in the state is to try to raise what's called the cap on non-economic damages. And so everybody in every state ought to be aware in their state what the cap on non-economic damages, and what that is essentially is it's pain and suffering. So, when you have a case and there's injury, there are the medical bills, there are the dollars and cents that you can attribute to what's gone on, but then there's this vague sort of squishy pain and suffering called non-economic damages. And states that have enforced caps usually have a much better med mal insurance environment with respect to physicians. So that's kind of a state by state thing. The other thing in the states is scope of practice. That's a quintessential state issue. And by scope of practice, it's who's able to practice urology in one form or another, and what procedures, who's able to do what procedures. And so a very common scope issue are APPs, nurse practitioners and PAs, trying to gain complete independence from physician oversight. And the nurse practitioners particularly have been very successful in many states, including my state of Maryland, at gaining complete independence. So my nurse practitioner, if she wanted to, could leave tomorrow and go 20 minutes away and set up a urology clinic. And there's nothing stopping her from doing that. And she doesn't have to have any relationship with any physician. For PAs, it's been a little bit more, it's been different. It's been much more focused on physician oversight, because that's how the whole profession came about of physician assistants. It was really supposed to be, a collaboration, a team, a physician assistant working with a physician to support the work they're doing, and to enhance that. But even in Maryland, there's a bill this year trying to really thin out that level of oversight and try to gain as much independence as possible. And it really becomes a quality of care issue. And so that's a state level issue that's going around. In Oregon, earlier this year, the naturopaths, so there's a board of naturopathic medicine, the naturopaths were trying to change a rule to suggest that they could do vasectomies. And so we caught wind of that and actually weighed in and did a lot of letter writing and finally sort of pushed that back. So no naturopaths in Oregon can't do vasectomies. But these are the sorts of things. People will start to creep around the corners and try to take over procedures that they think they can handle. And it's for us to be aware. And I will sort of hats off to Josh Webster, who's the AUA staff member in charge of the state advocacy committee. He's got his finger on the button. He's got dashboards of what's going on in every state. And that's what he does, is he said, hey, this is going on here. How do we want to respond? And Brian Duty is the chair of the state advocacy committee, does a phenomenal job of leading that committee and really figuring out where the fires are in the country and what can we do as a national organization to support, squashing harmful legislation, but also to support, the legislative agendas that we care about.
I think that's so important. There's so many things. We're all so busy that things fly under the radar. And unless we have a team that's actively looking for it, things will happen to us instead of us happening to things. So
that's right.
Yeah, I thank everyone for their time and their energy and making sure that we're aware and they're advocating for us, bringing it on the radar so we can squash it when we need to. Well, you were bringing up some other types of issues, sometimes social issues and thoughts. What is the role of the AUA with some of the more current social issues in urology?
So really, really good question. And this has come to light really in the last 4 or 5 years. It's interesting as an advocacy organization, we've been involved in advocacy for a very long time, is our national politics and our personal politics have become more and more divisive over time. Our opinions become stronger about the things we care about socially. And the AUA has a very broad constituency. Just looking at the political spectrum, talk about from conservative to progressive. it's all there. So we've got everyone, and so we hear lots of different opinions. A classic example is after the Dobbs decision by the Supreme Court, the AUA board, and again, with respect to commentary on social issues as an organization, that's completely the purview of the AUA board. They may or may not ask the Public Policy Council's opinion. In this case, they didn't, which is fine. That's their purview. They produced a statement, and after that statement was released, the feedback from membership was very interesting, and it fell into three different buckets. There was a group of people that said, we're urologists. You shouldn't even be commenting at all. Why did you even write a position statement on this? Was one. There was another group that said, that statement was so weak, you needed to come out so much stronger in favor of reproductive rights, whatever. And then others thought, yeah, that was over the top. You did too much. I mean, you should make a statement, but that was too much. So, you've got the whole beachfront of potential responses represented, which creates real challenges as an organization. So going forward, and there've been other social issues, and there have been actually individual legislators who have made public comments where people will call in and say, hey, we support this legislator. Like, what, how they're making these comments, how can you continue to support them from a PAC perspective? And so this is going to be definitely a challenge and a dynamic to be managed over time. And the best way to do that is to make sure everyone has a voice, make sure everyone's being heard, and increase the communication around these issues. Make sure there's an understanding of the way in which ultimately, if the AUA is going to weigh in on a situation, how that decision's made, and what ultimately happens. It's very interesting. After that, I mentioned that Dobbs position paper that the board put out. The board actually did a survey of membership afterwards, just generally asking the question, should the AUA be involved or express opinions about social issues that don't specifically relate to the practice of urology? And the response, it was a very good response to that survey. And taking everybody together, it was 50-50. So 50% of the membership said, absolutely, we should be getting involved in social issues. And 50% of the membership said, no, we have no business getting involved in these issues. And then when you broke down the demographics of the response, and so you could do sort of subset analysis, it turns out that the folks who were in favor of, yes, getting involved in social issues, you might predict, are the younger urologists, women, okay, tended to be, and they even broke it out by section. And you could predict that, like, places like the Western section and the New England section, yes, get involved in social issues. Southeast section, Southers, they were like, no, stay out of this stuff. So it broke down geographically the way our politics tend to break down regionally, but also by demographics, by gender. It was all not unexpected the way that broke out. But the bottom line is, the story there is, it was 50-50. So we have to move forward together with a bunch of people who have differing views about things, and figure out the way forward so that the AUA continues to serve all of its constituents in a way they can be proud of and satisfied with, in the way that we do good work. So these social issues aren't going away. And it's going to be one of my bigger challenges as I enter the chairmanship of the Public Policy Council in the next 4 years, is going to be making sure all of these constituencies feel heard, and making sure everyone understands that when the board ultimately decides to do something, why they did it and why it needs to be that way.
Yeah, I think that's an important comment. I mean, just our earlier conversation regarding the workforce, how it's changing, what it's going to look like in the future, and then making sure that people do have a voice. I think the younger generation is a little bit different. They want to be actively heard, and so to make sure that their concerns are addressed also. So kudos to the AUA for sending that out and doing a deep dive into truly what is the data and what is it showing us, and should we make any changes moving forward. So that was
Absolutely. Absolutely.
well, one of the things you mentioned was the AUA PAC. So tell me a little bit about that.
Yeah, so really, really excited about the AUA PAC. Eugene Rhee, who's been the Public Policy Council chair now for the last 4 years, together with Robert Bass, who's the chair of the PAC, Kevin Koo, who's a urologist at Mayo, who's been a fundraising chair for the last several years, have done a phenomenal job of bringing this PAC really from its infancy, really into solid adolescence. And the numbers of dollars of donation have gone up over the last 3 years, and we're on a really nice trajectory. And there are also newer mechanisms whereby sections can actually contribute to the administrative costs of the PAC. And so that's another initiative. But the PAC is really important to be on everyone's radar screen, because it is the mechanism by which we maintain our relationships with key members of Congress who are the ones who vote and push our agenda, medicine's agenda generally, but urology's agenda in particular. It doesn't happen without the PAC. And so, for folks who show up at the summit, great. And I hope more come next year than came last year. If you're of a mind to come and spend a couple of days listening to great talks and interacting with colleagues and hitting Capitol Hill, please come. But if you're of a mind to say, I want to have an impact, but I don't want to go to meetings, I don't want to get sort of tangibly involved, please think about contributing to the AUA PAC. Right now, it's something like 2 or 3% of membership nationwide of the AUA are contributors. It's a very, very appallingly low number. When you look at the Trial Lawyers Association, they're a several $1 million PAC, and they get nearly 90% participation. It's about a culture. It's the culture of your organization. They've developed a culture where the lawyers have, where it's just what you do. It's a cost of doing business. Just like you renew your license every year, you pay your board fees, you do the things you have to do to maintain all of the things you need to maintain to be a urologist. Contributing to your PAC should be on that list. And slowly over time, what we need to do, and what my goal is over the next 4 years, is start to create that culture in urology where it's just what you do every year. And I want to start with the residents. And I think we had a lot of resident contributions to the PAC at the summit. And again, it's not about the number, particularly for the residents. We know residents don't have money. Give $10, give $20, but do it every year. It's about developing the habit. And then as you get out into practice and you feel like you have some more resources, you can increase that if you feel compelled to. But every year it should be kind of in the back of your mind. I've paid my license fees, I've renewed my med mal, whatever it is. I gotta send some money to the PAC. It just should be what we do. And I think if we can create that culture and we get that 2 or 3% up to at least 50, 60, 70%, even small donations, all of a sudden we're $1 million PAC in Washington, D.C. And that's really the number. Once you rise above, you get on the radar screen. Urology's other PAC, EuroPAC, in the 2010 cycle, that was when Obama was running and Obamacare was being talked about, breached that $1 million PAC mark. And it was talked about in Washington. So lawmakers knew about EuroPAC because it breached that threshold. So we'll get it there. It's going to take some time, but we're going to get it there. But I want to continue to engage residents and academic institutions. And that's the other sort of big initiative with the PAC is historically, there have certainly been several academic champions of this PAC and members of the PAC board that have been from academics. But as a section of our House of Urology, relatively low percentage contributions from academics. A lot of it's been private and independent practice. So we need to continue to deliver the value proposition to academicians. And the value proposition there is research. We have a research appropriations committee completely designated to figure out how to maintain cash flows into urology research, but also improve that and make contacts with the appropriators on Capitol Hill who decide who gets what. How do we continue to funnel more and more money into urological research? And so it's a direct effect. The GME stuff, we all care about GME slots. We want to increase them. We care about training new residents. And so there's some real direct and tangible things that go on that I think are of import to academic urologists. And payment adequacy, by the way, oftentimes it's not, you don't think of it immediately if you're an academic because you're salaried by your institution, but the payment environment in the community directly relates to what you're able to negotiate in the inside of these academic institutions. And so payment advocacy, if it is you can influence Medicare and the private payers with respect to payment adequacy, that absolutely has impact on the salaries you can negotiate with your institutions when you're an academic. So that's another value proposition we need to kind of continue to develop and make to our academic friends and colleagues. But the PAC is so important. And then thank you for asking. And I just want to put that on everyone's radar screen. Again, it's not a dollar amount that's important. It's that you do it every year. So if you haven't done it, start a new habit this year. And if you have in the past, thank you. Please continue to do that.
Yeah, I think you really made an excellent point. No one is insulated from these changes. If we are not aware, academic, private, hospital owned, I think everyone needs to be aware of what's happening in the world because it will affect you. You can always wait for someone else to change it, but then you are at their discretion. So I think the more that we're involved, actively understand when we contribute our time as well as our dollar, I think the biggest impact can be made. We're not a huge specialty, but if we're not at the table, we're going to get whatever's left over.
You're exactly right. Completely agree.
Well, is there anything else you'd like to share with our audience today?
I think we've covered the beachfront, and this has been a really good conversation, been very comprehensive. So thank you very much for having me on. I really appreciate it.
Well, thank you for your time and expertise today. Thank you. And thank you, audience, for joining us at the AUA Leadership and Business Podcast.
Invest in your leadership and business skills at AUA 2024 with the Institute for Leadership and Business track. The ILB track features a total of 7 live courses offered from Thursday, May 2nd through Sunday, May 5th, with additional on-demand content to supplement. Whether you are starting your career, seeking career advancement or professional development, or looking to master the business challenges facing today's urology practice, the ILB track offers education to support your needs and professional growth. To accommodate the busy and robust schedule of AUA 2024 and to ensure that participants have access to all programs in the ILB track, each session will be recorded and can be accessed on demand, unless otherwise noted. Visit auanet.org/AUA 2024 to learn more and add the ILB track to your annual meeting registration. See you in San Antonio.